Hello and good morning. Today we're going to talk about application of the evaluation and management code changes that we discussed in the previous two videos, whether it be by medical decision making or time documentation, to some surgical cases. So let's begin. Well, the first thing I want to talk about are some of the myths that are costing us a lot of money. And the reason they cost us a lot of money is because we have some health convictions about how documentation should go that a lot of time make us get reimbursed less than what we should be. For example, things like I don't have time to document enough for a higher level code, or there is no reason for me to mention chronic conditions as diabetes and hypertension since I'm not treating them. Virtual visits are not real visits. It takes a lot of time to document enough for a level 4 or 5 visit. I cannot know what level I will code until I am done with the visit, or I will make my money in the OR anyway. These ideas, these concepts are holding us back, and we need to understand how to document in the correct and proper way so that we can get reimbursed for the work that we do without these concepts holding us back. So let's talk about them, and we'll talk about them as we go through different cases. In a nutshell, as of January 2021, the visit code is going to depend on only two things: medical decision making and time documentation. Before you even start with the visit, you need to have a basic idea about what level complexity this visit is going to be. You have an idea about what problems the patient is presenting with, whether there is a flare-up of the problem, whether you're going to order labs or x-rays or CT, or if you're going to interpret those results yourself, or if there is a moderate risk, a surgery to be discussed, and so on. These things give you at least a basic understanding of what level you will be coding for the visit. Now that may or may not change after the visit, but at least you're prepared to document to the level that you intend on achieving. After the visit, you look back and see what time did the visit take from start to finish. And when I say start to finish, I do not mean just the time spent with the patient. I mean all the time spent in chart preparation, in reviewing the case, in reviewing labs, in talking with the patient, answering questions, documentation after the visit, ordering labs or studies, discussion with other healthcare professionals, and so on. So all of these things will factor into the total time of the visit, as we have seen previously in the time documentation. Now, if that time is high, let's say it's 45 minutes for a new patient, or 30 minutes at least for an established visit, then you know that you've achieved at least level 4 just by time documentation alone. But the next step is to go for the medical decision making and see what kind of level did you achieve by the medical decision making. And in establishing the medical decision making, you need to look at the three things we talked about previously: the problem, analysis of the problem, and the risk involved. Did that analysis give you level 4 or level 5? Then if that is the case, then you need to document based on the higher one, which in most cases will be the medical decision making. So in most of the cases that you will see, the medical decision making will give you more level for the visit than the time documentation. The time documentation is used for those rare, complex cases where you spend a lot of time that exceeds the time that you can get, or exceeds the level that you can get by merely documenting the medical decision making and getting the code in that way. Let's start with the first case example. I am worried about this procedure. Beth is a 68-year-old female patient diagnosed with right side breast cancer. She had modified radical mastectomy surgery radiation treatment already. Her oncologist has referred her to general surgery for PICC line placement to start chemotherapy. Now, Jennifer is the PA assigned to perform this procedure next Tuesday. The principles that we're going to discuss and that we are discussing today apply to all practitioners, whether they are APPs or physicians. It's the same process for everybody. On Thursday, Beth calls to cancel the procedure as she is concerned about infection. Now, Jennifer makes a good decision to work the patient in for a virtual visit to discuss. All what Jennifer got was the information from the call that her nurse or the call center delivered that the patient wants to cancel because she's worried about infection. But she does the correct thing and works the patient in to talk about this decision to postpone or to cancel that procedure. During that visit, that virtual visit, the patient shares her concerns about infection, blood clots, and lymphedema. Jennifer reassures the patient, explains the procedure. So she says, basically, I do the procedure all the time. I have very low rate of complications. Show me your arm where we're going to go for that PICC line. Oh, this is going to be fine. There is no problem at all. I already see that we can have a good access here, so don't worry about anything. The patient is reassured, decides to keep her Tuesday appointment. She gets the procedure done without complications, receives chemotherapy, and goes into remission. So everything worked well because Jennifer made that decision to reassure the patient, tackle the problem, and have a visit to discuss this procedure before it is done. So after the visit, as we have learned, now Jennifer can look back and say, okay, how much time did this take me start to finish? And obviously it wasn't much time. So let's say it took 15-20 minutes. Well, that would put her in the category of 99202, the upper part of the screen. You can see that, which is 99202, a new patient level 2 code. Then she sees the medical decision making. And in this medical decision making, we see that the patient presented with one stable chronic problem, which is breast cancer. Now, here I need to stop and tell you something very important. It is very important to document the assessment that factors into the visit and factors into what you're discussing with the patient, especially if it involves some of the HCC codes. Now, what are the HCC codes? HCC codes are codes of chronic diseases that require a lot of management, require a lot of chronic care, and can have devastating complications on the person unless they are addressed. Examples include cancer, diabetes, osteoporosis, congestive heart failure, and so on. It is very important to mention the HCC codes that factored into your management because it gives a very high credibility and importance to the work that you are doing as an individual, but to the work that your entire healthcare organization is doing. The payers do not know, and the Medicare does not know how complex of a patient population you have unless you're documenting those HCC codes and telling how much of those patients you are treating and you're helping. The second part, second column, in addition to the problem, is the analysis. Now here, Jennifer did not do much of an analysis of the case. There was no review of radiology or any of the such things, so she gets minimal or none on the analysis. But the risk, there is definitely risk for that PICC line procedure, and that was the subject of the discussion with the patient. So we here mark it as a low level risk. It's not minimal, it's low. So based on this, on medical decision making, and as we saw previously, we only need 2 of those 3 columns to be at a certain level to give you that level. In this case, it was level 3 of a problem and level 3 of a risk, which gives you 99203. So which one was higher? Was it the medical decision making or the time? It's the medical decision making. As we said, this is going to be the case with most cases that you see. So it was the medical decision making that gave you the higher code, and as a result, you need to document 99203. Now, how much of a difference does that make? Had Jennifer decided not to call the patient or not to have the visit, or even if she called the patient but just on the phone or didn't have a visit documented, then in that cases she would not have any work RVUs for the work and effort and time that she spent dealing with this problem. However, by the proper and correct documentation that we just discussed, which is 99203-95, anything that is virtual visit, you need to document the -95 as a modifier. By that, you achieved 1.6 work RVUs, which is almost as much as the work RVUs for the PICC line procedure itself. The PICC line procedure is coded at 1.7 work RVUs, and it's almost the same as the visit that you did to prepare the patient for that and to alleviate the concerns. And that visit was consequential. So again, it goes to show you that virtual visits are every bit as real as actual face-to-face visits, because the decisions that are made, the things that you do, the information that you transmit and that you communicate during that visit is every bit as influential as the ones that you do during a face-to-face encounter. Let's talk about another case. My right knee hurts. Now this case is going to be very important, and I'll show you why, because it's really the bread and butter of all we do in clinic, whether it be for a general surgeon or surgical subspecialty, as we'll see in this case. Janet is a 56-year-old female patient with a history of diabetes, obesity, and degenerative joint disease. She is seen in follow-up visit for management of right knee pain. On knee exam, Bill, her orthopedic surgeon, finds no evidence of infection. Knee x-ray is done and read by Bill. There is osteoarthritis and narrowing of joint space. So he interpreted that study himself. He looked at the images and interpreted that study. Bill gives her a right knee corticosteroid injection, obviously after obtaining the consent from the patient. Bill explains that the steroid injection can cause an increase in glucose values, which is true, by the way, even if it is a local injection, epidural, knee injection, whatever it might be, it can increase the glucose values. And it's, I know it's not pertaining to the ICD codes and what we're discussing in terms of the codes, but it's a medical information that I believe is important. And as an endocrinologist, I just could not hold myself back from saying that. But anyway, he asks Janet to contact her PCP or endocrinologist to talk about the diabetes management and how to help this patient with the anticipated increase in blood sugar. Janet is instructed to take ibuprofen over the counter, but mentions that it tears up my stomach. So Bill tells her to take acetaminophen, 1,000 milligrams every 8 hours instead. Now, let's see how we're going to document and how we're going to bill for this case. First, we look at the time documentation. Did this case from start to finish take Bill, the orthopedic surgeon here, 30 minutes or more in level or in time spent? Now be careful before you answer, because anything that you spend and that you build for separately cannot be included in that total assessment. Here's what I mean by that. You cannot double dip. So if you did a corticosteroid injection and you billed for that procedure code, any and all time spent on preparing the injection, administration, giving anesthesia, if you give local anesthesia, anything dealt with that is a separate time because you billed separately for it. so it does not go into the E&M visit code. The E&M visit code is just the discussion with patient, preparing the chart, reviewing the x-ray, anything that has to do with that communication, but not including anything that you spent on a procedure that you separately billed for. Same thing goes for if you're, for example, doing an ultrasound. Let's say in gynecology, you're doing an ultrasound and you're billing for that ultrasound. Well, the time that you spent in doing the ultrasound and billing for it and documenting it does not go into the total time used for the E&M code. I hope this is clear. So basically the answer here is no. He did not spend 30 minutes. Maybe he spent 15 minutes with the discussion and reviewing the x-ray and everything, but not any more than 15 minutes. Now let's look at the medical decision making. From the medical decision making standpoint, this patient presented in the first column we see here with a chronic problem, degenerative joint disease, with exacerbation, a flare-up of her pain, and she also has two stable health care problems, which are the obesity and type 2 diabetes. In analysis section, which is the second column, the column in the middle, we see that he had something called independent interpretation of the test. He ordered an x-ray and he reviewed it himself. Independent interpretation, again, for reminder, is he's not reviewing just the report of that x-ray that radiologist had read. No, he's looking at the images himself directly. That is independent interpretation. And that fulfills criteria for a level 4 on analysis, because for level 4 analysis, you only need one of the 3 items mentioned, and independent interpretation of a test is one of those 3 items mentioned. Now, the third column, which is risk, there is definitely risk involved, maybe not specifically in the procedure itself, but medication management. Remember, he told the patient to contact her PCP for directions regarding how to manage her diabetes. Just by him telling her that is considered to be medication management, because he did administer a medication, which is corticosteroid, Medrol, or so forth, in the joint, and that will have an effect on the patient. So there has to be a change in how she takes her diabetes medication, how she checks her blood sugar, how she evaluates her blood sugar based on that. Again, Bill is an orthopedic surgeon. He doesn't need to go into those details. He's not supposed to, and nobody expects him to. But merely mentioning this and merely mentioning that he asked the patient to communicate with her primary care doctor because the blood sugar will go up as a result of the corticosteroid administration, that in and of itself qualifies as medication management, especially that he also asked the patient to take Tylenol or acetaminophen instead of ibuprofen. Now that is medication management. There is a problem, gastrointestinal upset, caused by medication that he recommended. It doesn't matter that this medication he recommended is an over-the-counter medication. It still has side effects nonetheless. It can affect the kidneys, can affect the gastrointestinal tract, and he directed her to another medication choice. By merely documenting that, you fulfill criteria for a level 4 of risk from medication management standpoint. So obviously this is level 4 visit, which again is a higher level that you obtain by medical decision making than the one that you obtained by time documentation alone. And as most cases, this is going to be based on medical decision making, not on time documentation. Because this case is important, I want to get 2 different scenarios of how this could have gone differently, but still you could have level 4 documentation and level 4 billing. So here in this variation, if you will, Let's say that he did not order an x-ray or interpret the x-ray. He just examined the patient, talked with the patient. She still has the same problems, and those problems must be listed in the assessment section of the chart. This is not difficult, doesn't take time, because you merely have to just click on that assessment from the problem list of the patient and bring it into your note. And then you need to say how that specific assessment influenced your visit. It doesn't have to be that you are involved in treatment of diabetes or obesity or any of the chronic problems, but if they affect your decision in any way, then that has to be listed on the problem list for this visit. So he needs to, the surgeon in this case needs to document the degenerative joint disease, the right-sided knee pain that is present, the diabetes that is present, the obesity. And those are things that influence his decisions, influence his visit, influence his assessment, and influence his treatment. Let's say that he also did this medication management with the administration of corticosteroid injection, with the discussion with the patient about acetaminophen versus ibuprofen. That is medication management. That is level 4 of the visit. And therefore, because he meets 2 of the 3 criteria for level 4, he gets a level 4 established visit. This is 99214. Now, this is important because there are some misinterpretations, if you will, out there of the guidelines that think that you have to meet all 3 columns in order to get the level for the visit, and this is not true. You see here in the upper left-hand corner of the screen where it says 2 of 3 determinants to determine level, meaning that you can have no analysis whatsoever, but because you have level 4 on problem, you have level 4 on risk, you get a level 4 visit. And by the way, one of the things that you will see, it's a theme that you will see over and over again in this medical decision making going forwards. A lot of times the analysis level will lag behind the levels that you get for problem and for risk, and especially when it comes to level 5. It's going to be extremely hard to get a level 5 on the analysis, but it's not that difficult at all to get a level 5 on the problem or a level 5 on the risk. Now, let's see here another variation of this same visit. Let's say that he did not give corticosteroid injection in the joint, and he did not talk about medications at all. Let's say that there was the problem, the same problems that the patient presented with, and that he did the analysis and did the independent interpretation of the test. He did get the x-ray, he reviewed it directly. Just by having those 2 columns at level 4, even with the risk being at low risk, he still gets the level 4 of the visit. Let's say that any of those 3 columns, if you get 2 of the 3 at a certain level, which is higher than the 3rd column, that higher level is used to determine the overall medical decision-making level for the visit. I hope this is clear, and I hope this example helped shed some light on it. So basically, the coding difference, if the surgeon had just regularly put in 99213, that would have given him 1.3 work RVUs. But if he coded the visit correctly as 99214, he would get 1.92 RVUs. Now, I can almost hear you say, okay, it's not worth the headache. That's not true. It's only a headache. It's only a lot of discussion here because we're learning something new. We're learning something that is you're going to implement over and over again. So I need to make sure that you get the principles right. That's why it's taking time. But in the real world, in the visit, it's not going to be taking time at all. It's just going to be a habit of documenting and billing at the correct level. This makes a big difference because if you code correctly as 99214 instead of automatically doing a 13 for all the visits, it's going to be a difference of 0.62 work RVUs. That is almost 50% higher in work RVUs. Now, based on the old system, which didn't give you nearly as many RVUs for a visit, for an E&M code, based on the old system, they did an analysis and found that if you just code one visit per day as level 4 instead of level 3, that overall gives you $10,000 more in reimbursement for RVUs in total per year. To be specific, it's 9,000 with and some change. So imagine if you did that for 5 cases per day or 6 or even 10 cases per day. Now, obviously, we're talking about correctly coding the cases. We're not asking you to increase the code for a case that you didn't qualify for a level 4. You should never do that. You should only document and you should only bill for what you actually documented. But if you are meeting the criteria of level 4 visit, and a lot of time you are, then you should document it and bill it as a level 4, not as a level 3. So I hope this makes sense. It's going to be extremely important for your practice and for all the surgeons to understand this and to bill in the correct way so that we get reimbursed for the work that we already are doing. Okay, now the third case is a case that says, I feel very tired. The patient is a 47-year-old female patient, name is Cindy, with a history of iron deficiency anemia due to menorrhagia caused by uterine fibroids. She is seen in follow-up virtual visit. Take note, this is a virtual visit by Ellie, her gynecologist. Cindy has a history of mitral valve prolapse with palpitations. She complains of fatigue that got much worse recently as her anemia worsened, despite an iron infusion that she received at the hematologist office. Cindy was evaluated by cardiology for her palpitations. Now, the gynecologist, Ellie in this case, had prescribed oral contraceptive pills, but they failed to control the bleeding, and patient states they made her feel miserable. This is not an option for her. Ellie reviewed the CBC results, pelvic ultrasound report, notes of hematologist, and notes of the cardiologist prior to the visit. During the visit, discussion of symptoms, treatment options, medication side effects was done. Ellie recommends total abdominal hysterectomy. Okay, Cindy, all we tried to do did not work. You're clearly still very symptomatic. It's affecting you in a significant way. We can't just keep on going and getting the iron infusions, and you're still not feeling better. I recommend the hysterectomy surgery. Possible complications and post-surgical hormone replacement were discussed. Obviously, many questions arise. Will I need to have the ovaries removed? Will I need to have the ovaries still, be left? What happens to my hormones afterwards? Do I take estrogen? Should I take? Is it safe to take estrogen? And so on. All of this takes a lot of time and explanation to do. Patient agrees to surgery after discussion of all the options. Ellie orders CBC, other preoperative labs, documents the encounter, and contacts the cardiologist's office for clearance. Now, mention here of contacting the cardiologist's office for clearance. The guidelines do not specify that you actually have to call on the phone and speak to the cardiologist. There are many methods of communication, and all of them achieve the same thing. It's very hard to get physicians on the phone, as any of us have tried. So if you try to call the cardiologist, is not in the office, you may not talk to him that day and so on. But if you text, for example, or use one of the software that you use to communicate that's internal to your hospital or healthcare setting, then you can text that cardiologist and say, hey, I need your help. I need this patient to be cleared. Please evaluate her as soon as you can because we need to get this surgery done. And the time that you spend in writing that text, in reading the reply, in answering any question, in communicating about the patient is a time that goes into the total visit as the total time for the visit, as long as it is done on the same day as the visit. So you cannot do it like 2 days later, for example, and have it as a part of the total time for the visit. It has to be done the same day. But you know, it doesn't have to be on the phone or face-to-face, can be by other methods of communication such as texting. So let's see what time was spent. 15 minutes were spent in document review and lab review. There were a lot of documents, a lot of labs, a lot of x-rays that had to be reviewed. 30 minutes were spent in discussion with the patient. And 15 minutes were spent in ordering labs, communication with other healthcare providers, and documentation of the visit in the EMR. So the total time spent is 60 minutes. Now, when you look on the next screen, which is of time documentation, you need to see how long that took you and how much of a code that gives you for your E&M visit. Here, when you look at the time documentation, and remember this is an established case, so you're looking at the second half of that table, the lower half of that table basically, and you spent 60 minutes, so that goes in that interval between 55 and 69, that gives you 99215 plus the code for prolonged visits, which is 99417. That is higher, obviously, than anything that you can get by medical decision making, because even if you went by medical decision making and let's say that you fulfilled all the criteria for a level 5, which you probably can in this case, then still that doesn't give you the prolonged code 99417. So as we agreed, you're going by the one that takes the more, that builds you higher, which in this case is 99215 plus an extended visit code 99417. I hope this is clear. What's the coding difference? Now, again, a lot of us who just don't want to just bother with it or spend too much time on this because we're focusing on other things, we would automatically bill as a level 4. If it's documented as level 4, which is 99214, that would give you 1.92 RVUs, which is obviously everything, all the RVU reimbursement for all the visit codes are going to increase as of next year. However, that still is too little compared to what you would get if you coded the case correctly. What is the correct code for this case? It would be 99215-95, because remember this is a virtual visit, plus an extended visit code, which is 99417, gives you a total of 3.41 RVUs. The difference is almost 78% higher in RVUs. This is, you're not getting something for out of nothing. This is the effort that you spent. This is your right. This is what you should be getting. Okay? There is no honor in leaving money on the table for the payer, for the insurance company, because this is your right. This is your work. This is what you did, and you should be compensated for what you did. So I hope this makes sense, and I hope you're beginning to see here how the correct application of the code can give you more reimbursement that you deserve, that you fully earned. All right, next thing, by the way, just before I move on to this slide, I just want to say something. It's true that the history of present illness and the exam are no longer factoring into the code that you are going to build. However, that doesn't make them less important. You have to document them because documentation in the EMR serves for three main things. Number one is communication, continuity of care. You're telling other doctors and other healthcare professionals about what's going on with this patient. This is the most important aspect of your documentation. The second one is for medical legal protection. You need to explain that you followed the standard of care and that you did everything that you could have done to help this patient. You informed the patient of the risks, you told the patient of a medication side effect if you gave it, and so on. And the third purpose is for documentation that gives you the coding. Just saying that the fact that HPI and exam are no longer counting towards your level of code does not mean to neglect them. You still have to document properly. Okay, the final case. They found cancer. John is a 73-year-old male patient with a history of coronary artery disease, status post-CABG, hypertension, and dyslipidemia. Recently diagnosed to have colon cancer on colonoscopy, and they took a biopsy, found it to be colon cancer. John already met with the oncologist. He talked with his primary care physician and with the gastroenterologist. Now, Chris is the surgeon scheduled to see the patient today. Before the visit, Chris obtained and reviewed the notes from GI, primary care, reviewed the labs, colonoscopy report, biopsy path result, and the CT images. He looked at the images himself. All of that took 30 minutes. Now, let me stop here and say one of the great things about the new system of coding, the new way of documenting the codes, is that it takes into account all the work that you used to do and you used to do for free without it factoring in any shape on your level of code. Now, that is no longer true because as of January 1st, 2021, all of this work that Chris, the surgeon, did is going to factor into the level of the code, and we shall see how. Now, Chris met with the patient, examined him, discussed the case. He had family members come in because obviously they were all very concerned. He explained the surgery, answering the questions, and so on. That took 40 minutes. After the visit, Chris contacted the oncologist to discuss the case. This is coordination of care, extremely important. Called back the patient to update him on the plan. Ordered labs, referred the patient to cardiology for clearance. Remember, the patient has a history of CABG and he needs to be cleared for that big surgery upcoming. Then he documented the encounter, and that took 40 minutes. Total time spent is 110 minutes. Obviously, because of the complexity of the case, that is a lot of time that was spent, but we saw how the time was spent. It's not just the face-to-face encounter. Everything he did pertaining to that case on the day of the visit counts toward the total time. Now, because it is a new patient to him, then you follow the upper part of this table, not the lower part, and you see here 110 minutes is in that final interval on your right-hand side, which is between 105 and 119. That gives Chris 99205, the new patient visit code, plus 99417 times 3. Again, one of the good things about this new system is that it rewards you for the time that you spend, and it gives you, it's easier to achieve those prolonged codes that do make a big difference in how much you are reimbursed for the work you are doing. So this is 99205 plus 99417 times 3. So let's see the coding difference. Now, most of us, again, we are in the habit, if we see a patient that is like, easier for us, we do 99203. If we see a patient that is more complex or difficult, we code 99204. And had he done that, Chris would have obtained 2.6 work RVUs. However, if he codes the case correctly as 99205 plus 99417 times 3, it adds up to 5.33 RVUs. This is more than 100% more in work RVUs. Again, this is work he did. He earned those work RVUs from Medicare or the payer or the insurance of the patient. He is documenting correctly what he did. He is not trying to get anything that he didn't do, but he is getting reimbursed for what he did, which is 5.33 work RVUs. Now notice that still that doesn't remove the need to document properly all the things he spent his time doing, even though he's billing by time. So that doesn't mean that now because he's billing by time, he shouldn't put any of the things that we discussed and that he already did in the documentation. He needs to put all the problems that factor into his decision in the assessment, and that's easy to do by just clicking on those items from the problem list, bringing them to the note. The coronary artery disease, the previous CABG, the cancer, and these are HCC codes. They are very important. Just by enumerating them on the assessment plan is a big thing. Then obviously anything that factors into his diagnosis from the problem standpoint needs to be documented. What he did and the discussion he had, the discussion of side effects, the discussion of problems, complications from surgery, everything needs to be also present. Now that is not as difficult as you may think it is, because as we have seen in previous videos, you can do the macros, whether it be on your EMR directly or on your software recognition, voice recognition software like Dragon. You can save a ton of time by documenting in that manner, but it gives you the right code and makes your documentation complete. So in summary, before seeing the patient, you have to establish complexity, have a basic idea of how much your visit is going to be in terms of involvement, in terms of analysis, risk, problems that you're going to see, and then you document up, meaning that documenting up is a concept where you know that this case is complex, but now after you're done with the case, you have to put in the points that show why this case is complex, why it takes you time, why it is high risk or complicated case or so forth. The second point I want to make is that level 2 is to be used in extremely rare situations. The way that the guidelines talk about a level 2, whether new patient or return, is that the patient basically didn't really need to come to see you. It's information that the patient could have gotten from the internet, or just common sense or wisdom or something like that, that didn't really require the patient to come for a visit. Somebody who's worried about something on his skin that is not any nodule or mass or anything to worry about. Now, how common in real life is that scenario? Extremely rare for a surgeon to encounter that scenario, and because it is extremely rare, level 2 is really used only in very rare situations. Most of the cases are going to be level 3 or up. Level 3 should be used for simple cases with no coexisting problems, low risk, take less than 30 minutes from start to finish. Level 4, however, you are meeting the documentation requirements and you are meeting the complexity requirements from the medical decision-making standpoint a lot of times, but your documentation needs to reflect that. So if your documentation meets requirements for level 4 or higher, either by time or medical decision making, do not be afraid to code the visit as such. A significant percentage of your work or views can and should be made in clinic. Now, I have not told you the bad news. I have bad news and good news. Let me say the bad news first. The bad news are that as of the beginning of next year, the reimbursement for your surgeries and procedures is going to be less. However, the reimbursement for the clinic visits is going to be more, and you can more than make up for the decrease in reimbursement coming from the surgeries by just properly documenting and not missing those codes that you've earned, that you deserve in your clinic. Virtual visits are every bit as real as face-to-face visits. The decisions, the level of risk that you take, that the patient takes, everything is as real as a face-to-face visit. Of course, there are limitations with the exam and so on, but that doesn't make the virtual visit any less than an actual face-to-face visit. Please bear that in mind. With efficiency training, you should be able to document level 4 and level 5 with small time investment. And I already made videos about the macros, but we're going to make more videos about efficiency, how to be efficient in your documentation and do all this documentation with minimal time investment. Finally, it is extremely important to document chronic health problems as diabetes, hypertension, coronary artery disease, cancer, if they affect your management in any way. Again, you don't have to interfere or to do decision about this diagnosis, but you do need to mention it if it factors into your documentation, if it factors into the decision you're doing, if it factors into the choice of surgery you're going to do, if it factors into the healing from surgery, if the patient has uncontrolled diabetes, if you're delaying a surgery until the patient gets their A1C down, that means that diabetes factored into your visit. This is extremely important. Can't tell you how important it is, especially for HCC codes as diabetes and congestive heart failure and cancer.